Welcome, everybody. Thank you so much for joining us. This is our Answers from the Experts live. We have two wonderful experts here with us this morning. We have Dr. Bradley Haverkos with the University of Colorado. Hi, Dr. Haverkos. Good morning.
Hi, good morning.
Dr. Haverkos is also a member of our Research Advisory Council for our foundation. And we also have Dr. Elizabeth McBurney, excuse me. Hi, Dr. McBurney. Good morning.
Good morning.
Dr. McBurney is an adjunct clinical professor of dermatology with Tulane School of Medicine. So we are thrilled that the two of you are here this morning, giving us your expertise and time this morning. Before we get started, I just wanted to give a pretty heartfelt thank you to our corporate partners and our individual donors, without whom we definitely couldn't put on these programs. So thank you so much for supporting us. So this morning, the way things are going to work, I'm going to stop my screen here. And just a reminder to folks as you're joining us, please make sure that your videos and sound are turned off. We do want to make sure we respect everybody's privacy here. And we ask that if you do have a question, you can go ahead and submit your questions in through the chat function. You'll see it at the bottom of your screen. There's just a little icon that says chat. And you can go ahead and just submit it to me, and I can ask your question live to our experts here. And that way we all are able to respect everyone's privacy. And if you've just joined us, you can also rename yourself if you don't want your name showing up on the screen. Okay, so we can go ahead and get started here. And I'm going to just ask the question aloud, and Dr. McBurney and Dr. Haverkos, I'm going to kind of leave it up to you guys to see who may be best suited to answer the questions. I know you both have different specialties here, so it's a really great opportunity for us to have some really great insight from different perspectives. So the first question that we have is, are people with mycosis fungoides more susceptible to developing other types of blood cancers, such as leukemia, multiple myeloma, or other types of cancers in general? And there's a second part of the question, but I'll just maybe kind of throw this one at you guys. Dr. McBurney, do you want to maybe take this one first?
I'll be glad to, Hillary. And first of all, I want to welcome everyone. I see we have 40 plus people on, and that's wonderful. Unfortunately, it is true that patients with mycosis fungoides are more susceptible to developing other cancers. And there have been a number of studies that have been done around the United States. One of the best known is the one out at Stanford, which showed that Hodgkin's lymphoma, non-Hodgkin's lymphoma, melanoma, and biliary cancer and that's the cancer of the liver, the system in the liver, have shown an increased incidence in patients with mycosis fungoides. Another study, in addition to those, showed that urinary cancer had an increased incidence or increased rate in mycosis fungoides patients. And I would also like to point out that we reviewed our 300 patients, and we were able to find that there was also an increased risk of chronic lymphocytic leukemia in our patients. So that I am always very cautious to my patients that they keep up to date with all of their wellness checkups, and if they develop any symptoms, that they do not ignore them, that they get them checked out if they're coughing blood or passing blood in their bowel movements, anything like this, that should be checked. Because there very definitely is an increased incidence of secondary cancers in our patients.
Right, thank you so much. Dr. Haverkos, did you have anything to add, or?
Yeah, no, that's a perfect explanation with a number of studies to support it. I mean, at the sort of base of cutaneous T-cell lymphoma, we think about it really as a cancer sort of the T cells, which is part of the immune system. And so kind of at its heart, the immune system isn't really working well. And anytime that the immune system is sort of not working in perfect synchrony, we tend to see some of these other cancers that pop up, because your immune system is really an important part of keeping cancer away. And so probably, you know, a bit speculative, but the reason that there is a bit higher incidence of getting cancer is because you know, at least a portion of your immune system is not functioning perfectly intact and perfectly as it should, and so thus kind of giving you some of these higher incidence of cancers that we see. I think there was a second part to that question.
There was. The second part was, do we keep track of individuals with MS and their causes of death?
Yeah, so certainly the short answer is we do. You know, there's been a number of retrospective analyses that have looked at cause of death in patients with mycosis fungoides. And there are certainly ongoing efforts to track patients and their outcomes. You know, at our center, we participate in a large prospective analysis of patients with cutaneous T-cell lymphoma, and we track from the time they're diagnosed to sort of as long as throughout their life, and look at what their potential cause of death might be. Now, in general, we think about cutaneous T-cell lymphoma, patients that have very early stage disease, which is the vast majority of patients. Those patients do generally well and have pretty good life expectancies, and life expectancies that's similar to their other sort of age-matched, someone else that would be sort of age-matched to them. And in general, they do just as well as other people without cancer, these early stage patients with cutaneous T-cell lymphoma. Now, advanced stage patients, they can die from the cutaneous T-cell lymphoma, but it's fortunate with new therapies and new options and better supportive care. I think hopefully that those curves are moving, and less people are dying of their disease in the advanced stage setting. Fortunately, there's a small number of patients that have advanced stage disease, and it's also possible that some of the new therapies are, you know, we're starting to use them a little bit earlier on, I think, in the course of their disease. And so maybe the course of the disease is changing. But again, these are kind of speculative things, and some of the some of the work that we're doing to track how patients do over time will give us some more of these answers and help us understand the natural course of the disease in kind of this new era where we have a number of new drugs available to us. I don't know if Dr. McBurney has more points to add to those things.
The only other point I would add, that was an excellent discussion, Dr. Haverkos, would be that in our patients with severe disease, probably the most frequent reason that we see the terminal event of death is infection or septicemia. And that's the most common cause of death in patients with far advanced disease. But I really want to emphasize what you pointed out, and that is over 80% of the patients with cutaneous T-cell lymphoma have early stage disease, which is very indolent, and they die of natural causes.
Mm-hmm. Yep.
Thank you.
Thanks. It's a good point to emphasize.
Thank you for that. Definitely. And just really quick, a note to everybody, when you're using the chat, you're able to select to privately chat me if you don't want everybody to see your question. If you do, that's fine too. But again, for privacy reasons, you can just chat it privately to me, Hillary Romke, and I'm the host up there in the top. Okay, so the next question, this one will probably be for Dr. McBurney. Is it normal for the itchiness factor to worsen during summer when it's hot?
Well, I live in Louisiana. You start sweating and get to, 100% humidity. The answer is yes to that, unfortunately. Not everyone itches who has this disease, but it's more common than not. And certainly it is worse in the summertime. And for that reason, I often emphasize to my patients how important it is to stay in good physical shape. And so I encourage them to do their exercises in air-conditioned gyms or air-conditioned houses rather than going out to jog in this, I don't, it's like going in the ocean when you go outside here. It's pretty bad. But certainly the humidity and the high temperature makes a big difference.
Yeah, Dr. McBurney, I'm always so I work with a dermatologist in our cutaneous T-cell lymphoma clinic, and I always learn dermatology through her as well. But I've sort of been told that, and you can agree with this, is that anything that's going to sort of cause inflammation to the skin, whether that's it's hot outside, it's sort of more humid, it's anything that's causing increased inflammation, whether you're working out, sort of exercising, sometimes these can bring out some of the worsening itchiness. So
absolutely, yeah.
We see it a lot in Colorado. People, it's very dry here, and then so people go to Florida and Louisiana and often come back with some sort of story about how if they itch, like Dr. McBurney was saying, not all patients with cutaneous T-cell lymphoma itch, but if they have itching, that they do experience differences based on the climate and temperature of that climate. Humidity also being a factor.
And our mosquitoes do their share too.
What's that?
And our mosquitoes add to all of this too. It's terrible.
Yes.
Okay, so the next question we have is COVID-19 related, and it's another kind of two-part one. Dr. Haverkos, you might best answer this first part. Does COVID-19 increase the risk of MF going into your internal organs or the lymph nodes? And then the second part is, will you have a more severe reaction if you have MF?
Yeah, I mean, these are great questions without good answers, unfortunately.
Yeah.
So I don't think there's any real evidence. So the first part of the question, does COVID increase the risk of MF or cutaneous T-cell lymphoma?
Yeah, going into your organs or lymph nodes.
Yeah, I mean, we don't have huge data sets to say that to give you real clear, concise, information that's backed up by a lot of evidence. But I don't think there's any real reason to think that COVID would increase the risk of MF going to your internal organs or lymph nodes. So that, to me, at least, it hasn't been a real big concern, at least the first part of that question. Time will certainly tell us unfortunately, more patients with cutaneous T-cell lymphoma get COVID-19, but I don't think there's a real good biological reason to think that would be a concern, and I don't think we've seen that to be the case. I don't know if Dr. McBurney has had a different experience or has anything more to add about that first part.
No, I don't, Brad. I totally agree with you.
And then, the other part, if you have MF, we have a more severe reaction to COVID. I think also it's hard to know exactly. I don't, people with early stage mycosis fungoides or cutaneous T-cell lymphoma, which is the vast majority of patients who are not on, systemic therapies, or just getting light therapy or other skin-directed therapy. I don't think that there's a huge concern that they would be much higher risk than other sort of people their age would otherwise be at risk. Now, cutaneous T-cell lymphoma tends to happen in an older population, so we know that older patients are more at risk for COVID-19 to begin with. So, but at least I don't have a huge concern that early stage patients are higher risk or have more severe reactions to getting COVID. Now, patients with advanced stage disease who are, their immune system is a bit more compromised, in part due to the disease, in part due to maybe therapies. I think there's concern that we definitely could have more severe reactions, especially patients, getting drugs that may affect their immune system in some way. And so I always kind of educate, patients to, in general, to sort of avoid COVID when you can, but especially the patients that are more advanced stage, that are getting more intense therapies, maybe more immune suppressive therapies, that it is even more important to be sort of vigilant and take precautions to avoid getting it, because of the fear that they could have a worse reaction than we otherwise would expect someone their age. I will say that we tried to look at a couple months ago. There was a group that got together that tried to look at sort of globally how many cases of COVID-19 there were among cutaneous T-cell lymphoma patients. And it was just too few to really say, to make much, to provide much insight into what the real risk is. But I think those are, in general, early stage disease. I don't worry about it too much, other than, how you would otherwise worry about it. In general, people more advanced stage, they get a little bit more concerned that they might. But again, we don't really know these answers because there just has been too few cases of people thus far. But Dr. McBurney may have more information on that.
No, and I think we've all cautioned our patients with cutaneous T-cell lymphoma to follow the caution of Dr. Fauci, where it's to wear a mask, to wash your hands, and to do social distancing. And we've actually, our lymphoma clinic we've tried to do more and more video visits to prevent them having to come into the medical center and possibly be exposed. Yeah. And we have not, as I'm sitting here thinking, we, among our cohort of patients in New Orleans, we've not seen any in our far advanced patients.
Yeah.
I could comment on what was the outcome.
Yeah.
With the COVID-19.
Yeah, I think those are great points. I think there's some nice information on the Cutaneous Lymphoma Foundation website too, that I often steer our patients to that provides the general recommendations outlined by Dr. Fauci and others. So I think our experience in across all of our blood cancer patients is that I think which includes cutaneous T-cell lymphoma, is that patients are more cautious than I think the average patient out there. So I think we see less of our patients getting it, maybe because they're taking the right precautions, which just furthers the point that if you take the right precautions, you're less risk of getting this. So I think doing the right things and avoiding contacts and big gatherings and wearing a mask all seem like they're beneficial. So
I'm sure, I know the COVID stuff is definitely on everyone's mind, and just as a reminder to make sure you check with your physician. They know your case the best. So it's difficult with the limited information that we have, but we appreciate you shedding as much light on it as you can. The next question is, recent information about COVID vaccines focus a lot on T cells. Since we have a T-cell lymphoma, how does this relate to us? That's a great question. And I don't even know if you can answer this one.
I'll try to answer it. That's fine. I think it's a good, interesting, good question. To my knowledge, most of the COVID vaccines are all inactivated viruses. So just in general, vaccines for patients with T-cell lymphoma or other blood cancer, if it is a live virus, it gives us some caution and probably should avoid live vaccines, but vaccines that include dead virus or inactivated vaccines are generally safe for people with blood cancers and including patients with cutaneous T-cell lymphoma. Even though it's a T-cell lymphoma, that doesn't mean that all your T cells are bad T cells. It only means that a subpopulation of the T cells that you have are sort of bad actors or are the cancer cells. So there's lots of other still good T cells that hopefully function well and will prompt a good response to an inactivated or dead virus vaccine, which I think most of the COVID vaccines are all inactivated, to my knowledge. So they should be safe in general for cutaneous T-cell lymphoma patients to get.
Yeah.
More than likely. Once we have one.
McBurney, anything to add?
No, I just want to expand that from COVID to the other vaccines, just to emphasize that it is perfectly okay to get the vaccines that have the inactive or not live virus particles in it. And most of those that do have the live viral particles are the ones we give to children, the measles, the mumps, the rubella, and not to our senior citizens. And the new zoster vaccine that has just come out, the Shingrix, is not a live virus. Yep. They are perfectly, that comes up a good bit asking, can they take that vaccine?
It does.
Yep. Yeah. Shingrix.
Yeah, we get a lot of questions about the shingles vaccine. That one comes up pretty repeatedly.
Yeah, Shingrix is safe. It's a good vaccine. I think in general, the only time adults have to worry about getting live vaccines is when they're traveling overseas, and you worry about some of those vaccines.
The next question is, what about running outside in the morning in a dry, hot environment without your shirt in order to get a little UV? Is this advisable?
Oh, I'd like to take that one.
Yeah.
If I may, as a dermatologist. Quite honestly, I have no problem with you running outside, but to do it with your skin protected. If you remember when we first started, we talked about secondary malignancies in patients with mycosis fungoides or cutaneous T-cell lymphoma. And this can, with excessive sun exposure, you can have a higher risk of melanoma and other types of non-melanoma skin cancers. So I do not see any reason why they cannot go outside and run as long as they put on their sunscreen, wear a hat, and use sun UV protection type sunglasses too. And I have no problem with that, but I would not go out just unprotected to get ultraviolet light as such.
Mm-hmm. Dr. McBurney, would you, I sometimes get patients that want to go to like tanning beds and things to get light to help their cutaneous T-cell lymphoma disease. What would you say about that on the similar vein?
Well, actually, I have to admit that there as with anything, there are exceptions. Yeah. And I do have some patients, for whatever reasons, that cannot come in and get light treatment, and I will suggest to them to go out and get natural sunlight for their light treatment. The tanning parlors, what concerns me about that is we don't know how much light they're getting, what kind they're getting, and who else has been in there. And so that I generally, when I have patients get natural sunlight, get ultraviolet light that's not in a medical situation, I suggest the natural ultraviolet light.
Yep.
How about you, Brad?
No, similar. I mean, we kind of covering a big state in Colorado that have lots of people that run into issues with getting access to things like photo booths and and other things to take care of their early stage CTCL with light therapy. And so we do have people that we recommend sometimes getting natural lights, similar to kind of what you recommended there. So when it's an option, we really like to control the environment as much as possible. And so when it's an option and feasible for people to come in and get UVB light at our center or another, good phototherapy center, it's really better for patients across the board, both from a risk standpoint and to better understand how they're responding to the therapy, to get it in sort of that controlled environment as opposed to light. But like you said, there's always exceptions, and in Colorado we definitely run into those plenty of exceptions where people live far away from us and it's not feasible to come a couple times a week to see us, and they can get natural light other ways.
Okay, so our next question, is it normal for MF to flare or get redder, itchier, new spots, and then have periods where it is less so? If so, what contributes to these flares, and are they indicative of the cancer spreading or being more active?
I'm sorry, Hillary, I didn't hear that first part of the question.
So I'll maybe chunk it into two different questions here. The first one is it normal for MF to flare, and they clarify, get redder, itchier, or new spots, and then have periods of time where it is less so? So basically, are flare-ups normal?
Absolutely. You will see that, and there's several situations in which it can occur. Sometimes when you're just starting therapy, such as using the skin-directed therapy of topical nitrogen mustard or using the ultraviolet light, a lot of times my patients with this early disease will say, I seem to be getting new lesions at the beginning of their treatment, which is the treatment is actually bringing out lesions that were already there and making them more obvious both to the patient and to the physician. But they're not causing the lesions. If patients are sick, and if they're, for instance, if they have poison ivy they get from working in their gardens, that alone can cause an exacerbation of the of mycosis fungoides or cutaneous T-cell lymphoma. And then they usually respond well to topical therapy, such as steroids or whatever therapy they're using, and kind of remit and go back. And it's not unusual to see a waxing and waning sometimes in their patients. What do you think, Dr. Haverkos?
Yeah, then those are all great points. I always try to make the point, and the dermatology team tries to make the point that often when you start light therapy, a lot of the disease can come out, and so not to think that that's progression or the light's not working, but that it just often brings out disease that was subclinical that we couldn't see before, and that with continued treatment it should get better. With systemic therapies, it's actually very similar in that some of the drugs we use, often there is the rash can get a little bit worse before it gets better, especially some of the immunologic therapies that work by probably driving a lot more inflammation to the site of the rash, the patches and the plaques and tumors, that they sometimes can progress, get a little bit more inflamed, more irritated, more red, prior to then seeing it resolve some. So I think those are important points that we try to make, both for skin-directed therapy and for some of the systemic therapies that rashes can get worse before they get better.
If there are only small patches, should other parts of the body be covered during light treatment, or is full body light treatment better since it is T-cell related? Another one for you, Dr. McBurney.
Well, my philosophy is if it's in two non-contiguous areas, And it's very, very rare. There's very, very rarely do you just see one patch of mycosis fungoides. If it's in two non-contiguous areas, I feel they should have the treatment to the entire body with protection of their eyes. And as we've already said, that can make other areas come out that were subclinical or not obvious. And I do think that you need to treat the entire organ of the skin when you're treating with the ultraviolet light. Now, as I said earlier, there's always exceptions. I think if you had a single lesion and you were using, for instance, radiation, then there can a case be made for just treating a single lesion or nodule. But generally with ultraviolet light, I would suggest treating the entire skin.
Yep.
Dr. Haverkos, I see you nodding. Anything to add or?
No, I think it just kind of brings to the point we were discussing in the last question, is that a lot of times there's disease, especially with patches and plaque disease, that we just don't see with our naked eye, and so that when we treat it with light therapy, it comes out. And so that just reinforces the point that if we only were to sort of spot treat or treat the isolated lesion that we see, that's not treating those other, bad T cells that we just are, can't see in another area.
Okay. The next one, what is the best way to get rid of the dark hyperpigmentation after you scratch yourself too much on your leg?
Well, that does not necessarily mean it's related to the mycosis fungoides. It may be related to the therapy that they're receiving, and it also depends on your skin type. People who hyperpigment after trauma to their skin, in particular here we're talking about the lower legs, generally if you avoid ultraviolet light exposure to that area, you're very diligent about doing that, by the use of sunscreens and protective clothing, it will gradually fade. Now, if you are receiving ultraviolet light treatment for treatment of your mycosis fungoides, then I don't think there's a whole lot. It's just, we're going to have to live with it, so to speak. There are bleaching creams that have hydroquinone in them that can very definitely lighten the hyperpigmentation that follows trauma. There is some over the counter that are 2%, and then there's some that are prescriptions that are stronger than that. But I will tell you, if you use the hydroquinone to bleach or lighten the skin and you go out in the sun once, it can repigment right away. So that the most important thing is to avoid further ultraviolet light to the areas of hyperpigmentation.
Okay. We kind of touched a little bit on vaccines, but somebody has asked, I would like to get a pneumonia shot. Is it safe for an MF patient to get this and other vaccines booster shots? Are there any that are not safe? I know we kind of talked about the vaccines here, but specifically the pneumonia shot is the question here.
Yeah, the pneumonia vaccine is perfectly safe. Again, if there's ever a question about a vaccine, important thing to ask is if it is a live vaccine, and if it is, then wouldn't get that one. But the majority of vaccines are not live vaccines, and so are safe. So Pneumovax is safe. Shingrix is safe, which is the new shingles vaccine. Flu vaccine, safe, and likely COVID once we get one.
The only flu one is, I thought, the intranasal one.
Oh yeah, that's live, you're correct.
Live. And so you want to be sure not to get that one, but all the others are fine.
Yeah. Yeah, we don't really, most time adults don't get we don't give too much in general the nasal one, so.
No, that's
yeah,
too
avoid the nasal.
I have recently been diagnosed with CTCL. May I continue donating blood? That's a really good question.
So most of when you go to donate blood, most of the time they'll ask you if you have, one of the questions is if you have a cancer diagnosis, and they'll exclude you if you check yes. So the short answer is that you're not able to donate blood.
Okay. Let's see. As I was only recently diagnosed with CTCL, should I notify all of my current healthcare providers, for example, my dentist, ophthalmologist, gynecologist, for example, of this diagnosis? So should you let everybody else know?
I mean, I don't, if you have a, early stage cutaneous T-cell lymphoma that is not requiring systemic therapy, I mean, I think, you should let them know, but it's not an emergency that, you alert sort of everybody. But most of the time when you go to, your internal medicine doctor, or your primary care doctor, your dentist, they'll ask if there are new medical conditions that you have or new problems. And it is important to just let them know that you have this diagnosis. Now, is it going to change anything for you? Probably not. I mean, you can still get any kind of dental procedure that you need. Certainly your primary care doctor should know, what's going on, and is an important part of, your health, and making sure that you get taken care of.
Yeah. I'd like to add, expand that just a little bit. I agree with what Dr. Haverkos said. There's not an emergency. You don't need to run to the phone and be sure you let everybody know. But when you go back in, to be sure that you tell them. And there's another reason too, particularly with your primary care physician or your internist. The incidence of high blood pressure is more common in older patients. And we want to be sure that they're not put on a drug that could exacerbate or worsen the mycosis fungoides. In this case, I'm talking about the hydrochlorothiazide, the work that's been done with that. And so I think that's real important that they review that with them. And that's not, that piece of information is often not well known among people, among physicians who do not handle a lot of patients with cutaneous T-cell lymphoma.
Mm-hmm. Yep. And certainly if, you have a cutaneous T-cell lymphoma that needs systemic therapy, we run into lots of issues sometimes around targretin and thyroid levels. So it's real important for, if you are on a systemic therapy, whatever that might be, to let your primary care doc and other docs know that you're on some therapy. And for example, targretin, there's, we run into sometimes some confusion because we don't necessarily look at one of the thyroid levels, the TSH, we look at the free T4 level. And that's an important thing because that's not the what primary care doctors tend to really think about. They want to adjust based on the TSH, and that's not how targretin and the thyroid level should be monitored and adjusted. So sometimes we run into a little bit of confusion sometimes. So it's important to let them know that, if, for example, you're on targretin or bexarotene, the other name for it, that it changes your can change your triglycerides and the thyroid levels. And just to let them know that, like, your cutaneous T-cell lymphoma doctors are managing this, and that they probably shouldn't change your thyroid level without consulting with your cancer doctors and dermatologists.
Okay. Let's see. The next one, I have FMS. Can you explain what information a T-cell gene rearrangement test would provide regarding my cancer? And then the second part of the question is, what would be a good test result and what would be a bad test result? Maybe for you, Dr. Haverkos.
This was a loaded question. So So FMF just meaning folliculotropic mycosis fungoides, where it's the sort of T cells are sort of focused around the hair follicle. But the question is really about T cell gene rearrangement, which pertains to all cutaneous T cell all types of cutaneous T cell lymphoma. T cell gene rearrangement test is a way that we can test to see if the T cells in a biopsy are what we call clonal. So cancer cells are clonal, meaning that it's the same population of cells every time. So sometimes this T cell gene rearrangement test is necessary to help us figure out and clarify the diagnosis of cutaneous T cell lymphoma. Now, it doesn't always need to be done on skin biopsies, but it can be helpful, especially early on when trying to get a diagnosis, or sometimes trying to tease out if something is a cutaneous T cell lymphoma lesion, or if it's something else that may be a helpful test to sort out. Now you can also test for T cell gene rearrangement in people's blood. So this is, we know that cutaneous T cell lymphoma is a cancer that primarily affects the skin, but it also can be in the blood and can progress lymph node disease or other organ involvement. Again, the vast majority of patients, it's just in the skin, it's just early stage. Sometimes this T cell gene rearrangement test can be done to sort out if there is blood involvement. But most commonly it's used in the setting of skin biopsies and trying to sort out I don't know if Dr. McBurney has more to add on that.
Unfortunately, I think some people tend to put a lot of weight on the T cell gene rearrangement. And actually, the diagnosis of mycosis fungoides can be made when that is negative. And so it's not a yes or no definite answer all the time. And to remember also that there are some conditions that are considered not malignant or pre-malignant that sounds like somebody, I've got some background here.
Yeah.
I don't know. That, and anyway, about some conditions that can have gene arrangement positivity that are not malignant. And so it's not an easy black or white thing. It's taking the clinical picture along with the laboratory picture, along with the biopsies. It's a total package.
Yeah, no, that's a great point to be made. To emphasize that not everything that is a clonal T cell gene or clonal T cell gene arrangement equates with cancer. It just can be a test that is sometimes helpful depending on the clinical context to sort out the diagnosis.
Okay, let's see, next question here. And just so everybody knows, I'm asking the questions in order of receiving them, and we have a lot of questions, so if we don't get to it today, I apologize. The next question is, which cancers are most often seen with MF? Or other cancers, I assume.
We kind of talked about this early on in the discussion, and I think that, as we said, the non-Hodgkin's and Hodgkin's lymphomas fall in that group. Melanoma does, biliary cancers, urinary cancers, chronic lymphocytic leukemias. But really, I suggest, and we've also seen a significant number of lung cancers in our patients. And then there are the that we look for, but I think there is an increased risk of secondary malignancies.
Let's see. If someone is in the early stage and only has patches or plaques, do you recommend TSEB therapy for that person?
TSEB stands for Total Skin Electron Beam Therapy. The first thing I would recommend before I talk about therapy is I'd want to know what percentage of their body surface is involved with the disease. If it's less than 10%, which would put it into a stage 1A, I would not start with that therapy. I would probably start with more skin-directed therapy, such as ultraviolet light, such as topical steroids, such as topical nitrogen mustard. Now, if you have gone through those and you have not completely responded and the skin is getting considerably worse, then total skin electron beam is an option. The problem with total skin electron beam is that it has a lot of side effects that people have, and they have, it can cause, and also it requires you to be near a place that you can go several times a week to get the therapy. And you cannot get people, many medical centers do not even offer total skin electron beam therapy. Usually it is only in the centers that around the country that deal with patients with cutaneous T-cell lymphoma. So it would not be my first go-to therapy. Now, I do use total skin electron beam therapy in someone that has more far advanced disease that I'm trying to decrease the tumor load in them or to decrease the itching. But that is more in a palliative method rather than trying to treat the disease primarily.
Yep. I think before, it's always hard when you get questions about sort of, what we would recommend in terms of your therapy, because everybody's unique and cutaneous T-cell lymphoma is complicated. Every individual that has it kind of has a different story and sort of different tempo of their disease or different flavor of their disease. And so what's right for one person might not be right for someone else. And it all depends on sort of what therapies you've had previously and your other medical conditions, certain things we may not advise if you had, a certain medical condition. So I think it's always challenging to answer some of these questions about, is that right for me without sort of knowing all the information. But TSEB or total skin electron is a good therapy in the right context. But usually, like Dr. McBurney was saying, we tend to go first with light therapy and other skin-directed therapy before going to TSEB.
Okay. And just another good reminder to make sure to check everything with your own physician since they know your case best.
Yep.
Okay, so I just started romidepsin. When should I start feeling improvement, and what is the effectiveness of this drug? And they kind of made a side note. It seems like I have had symptoms for a long time, but it took a long time to be diagnosed. Why is the diagnosis so difficult? So two-part question here. So first part, when should I feel improvement from the romidepsin?
So it takes a couple, like most drugs, most therapies in cutaneous T-cell lymphoma, it takes a couple months to know how well the drug's gonna work for you. So I assume that the question is related to feeling better, meaning feeling like their skin's getting better, which the answer is a couple months. Usually we'll start to have a sense of how well the drug's gonna work or not work for you. There are certainly potential, so romidepsin, especially in patients that are older, sometimes can have a lot of issues around GI or gastrointestinal problems, so like nausea, loss of appetite, just sort of, so if those are the sort of symptoms that are, having, that stuff doesn't necessarily get better. It can be managed a little bit better, somewhat controlled better, but it might require dose reduction of the romidepsin too at some point. So I think these are all important things to sort of discuss with, your doc that's prescribing the romidepsin. But in general, most therapies take a couple months to see how well they're going to work.
Right.
What was the second part to that?
The second part, was that I have had symptoms for a long time, but it took a long time to be diagnosed. Why is the diagnosis so difficult?
Yeah, so we probably can both take a crack at this one, but unfortunately, the median time from rash to diagnosis is a couple of years. We're getting a little bit better and about maybe diagnosing it a little bit earlier. But in general, the initial findings or initial rash and initial, even if you get a biopsy initially with that initial rash, sometimes the findings on the microscope are subtle. The rash can be subtle. The rash can, look like other things like eczema, So there is problems that is a rare condition. There are much other more common conditions that can kind of mimic it or look similar to it. So sometimes it just takes time to figure out that, oh, this isn't responding to the normal therapies, and maybe need to think about an alternative diagnosis. And then also when you get a biopsy, sometimes the biopsy is not always clear. Sometimes the findings are subtle for cutaneous T-cell lymphoma, especially early on, and it often takes a pathologist that excuse me. It often takes a pathologist that has a lot of experience in cutaneous T-cell lymphoma to pick up that diagnosis. So, sort of lots of issues around, why it might take some time for any given case, but unfortunately, it doesn't seem to negatively affect outcomes in the disease. So even though it may take a couple of years to diagnose, we still can treat it just the same, and the outcomes likely are just the same. Excuse me.
And I always reassure my patients, a lot of times they're diagnosed with eczema or psoriasis or atopic dermatitis, and they're frequently giving steroids to treat that. And remember, we said earlier, steroids is actually one of the treatments in early mycosis fungoides. So we'd like to be able to do it early and more accurately, but sometimes it's just not possible. And the other thing is that the physician has to think of the disease. You've got to think of the disease to diagnose it.
Mm-hmm. Mm-hmm. That's a good point. Let's see. So the next one, dermatology related here. What over-the-counter vitamins or minerals or homeopathic remedies do we have any published studies indicating that, let's say, regular use of certain foods or topical creams is beneficial intradermally? So a couple of questions kind of there. It's a tough one.
Well, I'll take a try at it, and then I'll turn it over to Brad.
Okay.
At this point, I do not recommend a particular vitamin to help the mycosis fungoides. I do recommend that people, if they're not getting ultraviolet light therapy, I recommend them to take vitamin D. And I also, since it tends to be an older population, not always, but more commonly, I will often recommend a calcium vitamin D supplement to them. I am not aware of any good studies that have been done that have shown that a particular type of diet makes a difference, or a particular vitamin or metals such as magnesium or selenium or any of these make a difference with mycosis fungoides. I encourage my patients to eat well, not to be overweight, to exercise, to stay in good health and keep up with all their well health checkups. But I do not personally recommend a particular diet. One that sometimes comes up is about a gluten-free diet, because it can potentially decrease the inflammation in the skin. And I'm not aware of any study that has shown being on a gluten-free diet, if you don't have celiac disease, makes any difference at all with the mycosis fungoides.
Yep, I completely agree. I don't know of any data to say that it's beneficial to do a certain diet or take certain supplements or herbal things. I mean, in general, I sort of adhere to, telling people to be healthy, to sort of eat a healthy diet and exercise, and you can't go wrong with doing those things. If you want to take a multivitamin, that's safe, it's fine. If you want to take, vitamin D supplement, that certainly doesn't seem like it hurts, and there may be, may be somewhat beneficial, especially with how common people have low vitamin D in our society. But beyond that, there's no data to say that, there's no data I'm aware of. And usually when people take all the, a lot of supplements and vitamins, it really just amounts to really expensive urine, because you're peeing out most of these extra, all these vitamins.
I like that.
That's right.
Oh my goodness. Okay, so just because of the time, we have time for one more question here, and then we will be signing off. The last one is the age a factor that must be considered before starting any treatment?
Yes, I think I'll answer that partially, then turn over to Dr. Haverkos. I think age is important. For instance, if you have an extremely elderly patient who cannot stand up for a very length of time, it's going to be very hard to give them any kind of phototherapy with ultraviolet light or the total skin electron beam.
Mm-hmm.
And so that makes a big difference. The other age factor that comes in is that generally as people get older, they have more what we call comorbidities. And by that, I'm talking about high blood pressure, high lipids, high cholesterol, high triglycerides. And so those factors need to be taken into consideration in picking out drugs such as the targretin or the bexarotene. And then also, we need to remember we don't just see it in elderly, we see it in young people too. And we have to be careful about them not becoming pregnant on many of these drugs. And so I think age is very definitely an important factor in selecting a therapy.
Yeah, those are all great points. It's, everybody's, or every patient, every person with cutaneous T-cell lymphoma has kind of a unique story or unique aspects, that whether they're related to their disease or related to other problems that they may have, whether that be age or another medical problem, or whether they want to get pregnant, whether, these things all factor into what the best treatment might be for any individual person. So these things are all really important. We have a decent sized toolbox of different therapies that we can, go after cutaneous T-cell lymphoma. So, figuring out and sorting through what the best therapy for any individual person is really kind of the job of your doctor, and discussion with your doctor on sort of what options would be best for you.
Yeah.
Okay. Cool. Well, it is just shy of 10 o'clock here, so we're going to wrap up. And thank you so much, Dr. Haverkos and Dr. McBurney. We're all giving you a virtual round of applause here. So thanks for spending your Friday morning with us. And thank you, everybody, so much for tuning in. This will be posted on our website within 10 business days, but likely next week, so you can rewatch. And thank you again. We're so appreciative of everybody's time. So thank you, and I hope you all have a wonderful rest of your Friday and a wonderful weekend.